Hello and welcome back. I'm Eric Sunset, your host of the DocBuddy Journal. Here at DocBuddy, we deliver healthcare solutions that take the pain and cost out of broken workflows like OpNotes, which gives ASCs the power of instantly generated operative reports approved from the point of care. You can learn more about that and more at docbuddy.com. Today, we're joined by a special guest, Rena Courtay. Rena is VP of Ambulatory Surgery at Trinity Health, and she's also a member of the ASCA Board of Directors, in addition to being a longtime ASC expert. Rena, thanks so much for joining us.
Thank you for having me, Eric.
It's going to be a lot of fun to have you on the show, and I know everybody at DocBuddy is really looking forward to the upcoming ASCA annual conference, 2 weeks away. And this is an event that you are once again speaking at. What can you tell us about your talk without giving too much away?
Well, my talk this year is titled Finance Basics for Clinicians. And being a nurse, it's kind of near and dear to my heart because in nursing school, like medical school, you don't learn about finance really at all. And then you get in healthcare. And if you become a leader of any sort, you need to be learning about finances and how that impacts the bottom line and how what you do as clinicians impact the bottom line. And we have a lot of, nurses running ambulatory surgery centers. And sometimes they got those jobs by default. Sometimes, they were running the operating room or they were running the pre-op PACU, and then all of a sudden they're the administrator and nobody's told them, hey, half of like a lot of your job is financial management and fiscal responsibility, a fiduciary duty to the partners and all these things. And they're like an income statement and all those type of things. They just don't know. They don't know about those things and how the different things they do impact that.
Absolutely. And, in your experience, and again, without giving too much away, because we are just a couple weeks away from ASCA, what are some of the biggest blind spots you see other than just, hey, how do I even read a P&L? What's a balance sheet?
Well, exactly. And one of the, staffing, I see a lot of common things, but staffing's like our biggest cost right now. It is, it's the biggest cost percentage of your net revenue. And a lot of them don't even, it's like, oh, how do you get the net revenue? Let's start with that. But, when you're talking about expenses, staffing, people oftentimes, especially nurses, and I'm a nurse, so I know this happens, they staff the place for peak volume. Well, on this day, we needed, all of our operating rooms are running and we need this many staff. So then they hire that many full-time staff. Well, what do you do on the next day when your volume is half what it was? Or, because in ASCs, the volume fluctuates. Every ASC, no matter how busy it is, it fluctuates very frequently. So you have to learn about that and how that impacts and how your labor hours per case, how that impacts your financials. So that is one thing. Supply costs, how, you know, especially if you come from a health system, a lot of times you've worked in an environment where you get whatever, the doctors get whatever, especially an academic medical center. That's the worst one. Where, oh yeah, they get whatever they want to get. And we have to be very cognizant of our supply costs, how that affects what are we getting reimbursed for a case. And that's all stuff they may not know when they become an administrator of a surgery center, if they're coming from the nursing field. So how do they figure all of that out? Another big one is, you open a new ASC or you buy new equipment, you take out a loan and you finance a lot of money. Well, yeah, that you forget about that. It's not really in your, it's under the line. But when you're talking about cash flows and distributions to your physician partners, it's very impactful. And, I've bought centers in the past where the doctors can't understand and nobody understands why they're not profitable because, their supplies, their staffing and all that is in line with well, below the line, you've got this much in interest payments. So you've got to generate that much cash to pay for that
And I
before
would
you
imagine,
can pay, before you can give a distribution.
And I would imagine it goes a long way to having that financial literacy with the administrator within the practice. I've seen this in the past, and I don't know how widespread this experience is, but like, doc, yep, we have to service this note. There's this much cash that needs to come in before any cash can go out to anybody. Who told you that? Was it the accountant? I don't think so. Call them again, tell them they're wrong. It's like, well, no, because that's how it works. We don't need to call the accountant and get a second opinion. This is how finances work.
Right. I mean, the cash is the cash. It's like, even though we use accrual-based accounting, and that's another thing people often don't understand, the accrual-based accounting. And I don't even know that I'm going into that with my talk because that's a little more advanced talk. But, how does that work, and how the supplies you order and you ordered them that month, then, you have to accrue for those expenses. They don't, that is, especially coming from physician owned centers, people don't often, because physician owned centers usually work off cash based accounting.
Sure.
Yeah. So then you get into all that, but I don't think I'm getting into quite that much detail this time.
That'll be the level 2 talk after the event for the day is over. You can find Rena at X, Y, and Z
Yeah,
spot, and she'll give you
we can
the
talk about that. Any more detailed talks?
well. And some of the things you're hitting on, I'm not sure that it's ever been any different. However, the ability to project and to measure and track, because you talked about some pretty important things: staffing for given block time, utilization of surgery hours and operating rooms, versus the cost of supplies, versus the reimbursement that you're expecting. Not expecting is a key word there. You can have a pretty good idea, but guarantees maybe a little bit too strong. But you have all these forces coming together. We hear from ASC administrators that there are certain types of procedures that are going to be a loss if you're not looking ahead and you don't understand that that's a possibility. So, in that sense, what can you do to stave that off, or what technology and what data do you need at hand to be confident that every procedure you perform will put you in the black?
Yeah, and that is a really important thing, and you have to educate people. It's educating your staff, your business office staff, the surgery schedulers at the doctor's office, your scheduler at the surgery center, the surgeons, because if they're investors, hopefully they care about these things. They don't want to bring cases that are going to lose money at your place, and then if they're not an investor, they may just find that you're not going to do that case because it's going to be a loss, so you're going to say sorry, you have to go somewhere else for that. But you have to understand all of your payer contracts, and you have to understand the ASC Medicare fee schedule, because that typically it's a minimum, I'd say, no matter where I've been, it's a minimum of 25% of your business is Medicare or Medicare Advantage, which is basically the same reimbursement. So you have to understand it. And typically that's going to be the floor of your reimbursement. So if you know what that is, and you know that you're not going to make money on that on Medicare, you're probably not going to, then you can look at other things, your commercial cases. Are you going to make money on that? You may, because Medicare doesn't pay for implants, for example. So, you have to understand all this. What I like to do is, have a pretty detailed you call it a cheat sheet. I call it a stoplight report, but it has for every specialty, or in ortho, every subspecialty, because those are very different. Orthopedics is not just orthopedics, because hand, total joints, sports, foot and ankle, all those things reimburse very differently. And the costs are different. So you have to, put your most common CPT codes on this thing, put all your payers, your main payers, and Medicare. And then I came up with the system I just color code that for offices. And if that CPT code is green, that's good. You can do it. If it's yellow, then we need to talk about the implant costs. If it's red, you really don't want to do that here. So to try and help educate and make it easier for people to figure out what they can and can't do at the office and at the surgery center too. And then, educating people on the costs of the case. Physicians usually, if they come from a hospital, they have no clue what anything costs. And why would they?
No, it's fair.
But when they come into a surgery center, hopefully they want to know this stuff because they're an investor and they have, they care about it, and they should care anyway because it's overall about the cost of healthcare in the US, and how high it is, and they can be drivers of that. And also, if they're too high cost, as I've told many of them in the past, the insurance company may find you're too high of a cost provider. They don't want you in their network.
Can
They're
happen.
measuring these things. So, really educating the physicians on the costs and the reimbursement. Whenever I onboard a new physician at a facility, I recommend that at sitting down. I mean, it takes a couple hours, go through all this stuff with them so they know, and keep them updated on, hey, this is what, and we may call you about this case because it's too expensive. And we need to see if you could use something else, or is there an alternative? What can we do? Because we want to do the case, but we don't want to do the case at a huge loss.
Well, and with, again, everything coming together, this confluence of factors, the insurance reimbursement, the cost of the implants, just your cost to have the lights on and have people in the building working for you. Your stoplight report sounds like it's bringing together a few of these different pieces of data. I would imagine it takes less time than you would think to put it together. Not to say that it's fast,
Yeah.
but or necessarily easy, but I would imagine that comes together pretty readily, and then you've got sort of a bulletproof system to know, like, we really can or cannot do this procedure or want to do this procedure.
It's a really helpful tool. I have to credit one of my orthopedic vice chairs at Duke for helping me think of that. And then I just sort of came up with the format. But she was like, we need something to help the offices, and I'm like, okay, what can we do? And that's sort of how we came up with that, to make it simple, because they don't need to know the actual reimbursement for every single thing. But if you put in the Medicare reimbursement for the CPT codes, then you at least usually have the floor, except for maybe Medicaid. Medicaid's usually worse, but you'll have, it gives you a good idea of where you are with those CPT codes.
For our listeners out there, and many of them are in the ASC space, maybe don't have the level of support that you provide to your centers. So the reimbursement data is pretty easy to pull together. That
Yes.
ought to be in your PM system, or search for through your file of contracts for things that you've signed and accepted. How can you figure out the cost to the center fairly
Yeah,
easily?
and that's, that is a piece that is a little more challenging. I mean, we haven't used a lot of electronic inventory systems or anything like that at ASCs. It's getting a little more prominent depending on, if you're part of a management company or a health system, maybe you have more resources on that front. It's typically been you take the preference cards of the doctors and, you cost out everything that's on there, and it's been pretty manual process. Sometimes people have loaded them into their patient accounting systems, and you have to keep up the pricing, of that. It's a lot of manual work when you don't have an automated, barcode scanner or something like
Mhm.
that to manage inventory. It's manual, but it's really important, at least for the higher cost cases that you are on the edge with, especially orthopedics, because a lot of it is Medicare. And, if you've got a hand surgery, this happens a lot. And the more technology we come out with and little gadgets and whatever, and you're going to get paid $1,400 for that from Medicare, and you're using, two products by a certain manufacturer called tight ropes, and they're 800 and some dollars a piece. And then you put a nerve graft shield on there and it's like 2,500. I mean, you're at like $4,000 for three things, and that you're only getting 1,400 for the case. So these are the kind of things that easily happen, and you don't always know, because the other thing that happens is reps come in and they give the doctors things in the case that you didn't even know were on the preference card.
Mm.
And you have to have a process in place to eliminate that from happening, because if it wasn't okayed by you and the administration of the surgery center, and that got brought into the OR and utilized without anybody's A-OK, then my stance on that is that rep needs to eat that.
Either that or consent to a strip search the next time you walk into my facility to
Yeah,
make sure you know
because
what you got on
that
you.
kind of stuff happens a lot because there's so many reps in the OR with orthopedics especially.
Oh
You
yeah,
know, you're coming in with all kind of things, and some, you know, you get and you're like looking at, what is this? Who said you could use that here?
right.
You know, and the doctor doesn't know, and they don't even know how much it costs. They're like, oh yeah, that looks cool. I think I'm going to try that. You know,
Sure. Well, that pref card exercise is interesting, not only just from the kind of the accounting or the projecting a cost on the procedure side of things, but I would imagine that yields some dividends too. Like, hey doc, this pref card hasn't changed in a decade. Like, what's going on? We can do better than all these. Or you tell me because I don't work in an ASC.
well, and then the other thing that's really good, if you have a few doctors in a given specialty, or even like in ortho, like it's got to be the subspecialty, then you can, you know, benchmark them all against each other. And for similar cases, that's a great method that's tried and true. Hopefully, you have a better electronic. If you had Epic, it's easier to do. Honestly, that's one benefit of something like that. But you can do it. And if you had a bunch of ophthalmologists, I mean, that's a real easy one. And you know, you've got a cataract. It's a cataract. You have 10 ophthalmologists, and you do their average cost per case, and you show it to them at a meeting. Well, none of them want to be the highest cost per case.
Oh no. Oh
They don't
no.
like that. And especially when you show it in a group like that, and then you just get them talking to each other about what they could do. And you just really have to set the stage for it, and then they start having these conversations with each other about what can they do to lower their costs. And even then they're going, well, what about this? What about that? Ortho does it. I've seen it. It's fun. I like to sit there and watch because they know what they're using and why they're using it and what the alternatives, and then they're talking about techniques, you know, surgical techniques
Mhm.
oftentimes. Well, you could do this, what about that? And it really spawns a lot of great discussion, and that's a really good way to reduce your costs, is have them engaged in things like that and show them where they fall as relation to each other in given cases.
And
Like
we all
for
know
ortho, total joints. Okay. We did that, my last total joint program at Duke. The docs were great. They wanted to know every month. We updated the data every single month as to the cost per case for hips and knees for each doctor. They wanted to send it out to every doctor. So every doctor sees every month where they're falling in terms of the total cost for their implants and supplies. And they also wanted to include stuff like the length of the case and all these other things, so they could really watch each other. And I tell you, I didn't have to do much, but they all lowered their cost of care over a year. I mean, just like it just kept going down by doing something like that. And they weren't even owners, but they were
no.
very engaged in this, you know,
The
because they wanted to lower their cost of care.
the public scoreboard for even a moderately competitive group is such a powerful tool, and there's not many surgeons I know that are only moderately
No,
competitive. So
and especially ortho.
right.
Ortho's number one competitive because they were usually in sports, very active in sports in school, and may have played sports in high school and college and all that. So they tend to be a really competitive group.
And that's awesome when they're bought into the mission of the center and competing with each other for the best outcomes. The best outcomes with the least expensive costs, I imagine, is a pretty sought after title.
Right. And it's not because we don't want to obviously have lower quality or
No,
bad patient outcomes or do things that are detrimental to patients, or, well, this is not as good. We would never want that. Not as good is not what we're looking for. We just want to have the best outcomes with and the most cost efficient.
highly optimized, I think, is the phrase we should be using there. And in that same vein, when you look at the adoption of technology by ASCs, that curve is steepening. Obviously, ASC is spared from any type of meaningful use type law, at least for now. There's kind of some whispers out there. But it's exciting to me to see ASCs freely adopt these electronic health records and other digital workflow tools in their centers, aside from sort of the basics of better record keeping, better quality reporting, being able to submit data to registries more easily. Those are kind of like the no brainer, like, yeah, of course, any EHR is going to help you do that. What do you think is the most exciting aspect, though, sort of beyond the basics, Rena, of starting to see ASCs really wrap their arms around tech?
Well, the EHRs are getting more common in ASCs because the cost to get in on the main ASC EHR platforms, which there are only really a couple that are truly for ASCs, they're seeing, oh wow, it's not going to cost us that much more to get to implement the EHR piece. They may have already had the patient accounting software from those vendors, and then they can add on the EHR, and it gives you just so much more opportunity to aggregate your data, look at your efficiencies. You can have so many more templates set up and shortcuts, I'd say, to standard documentation. Your patient estimates and things like that can be more automated. Hopefully you're using online patient registration and things like that make that's a huge time saver, because, and we've been using it for years in many ASCs, but a lot of people weren't. And, the average time on a phone call for a pre-op phone call is like 20 minutes.
Oh my
That's
gosh.
like, 20 minutes. That's one person, 20 minutes times however many patients you have. That's a lot of labor to ask questions that you could get the patient to submit online, obviously. So hopefully you're doing that. And, if you don't, you should investigate it, because having the online patient registration with these EHRs too, they can do online scheduling. The offices, instead of calling and, hey, talk, they can put it like into a depot or whatever, and you can schedule online into the block time or open time that's available at the center, instead of having to be on the phone, and maybe you didn't get your phone call answered right away. And, it's just it's such a time saver for a lot of these things. And I think the more we can use it, the other thing is patient communication, getting texts to patients and to keep, or family members keep updated on what's happening, or let them know whatever you want to let them know. You can even, some places I've heard of are using those texts to determine if the patient needs or wants a post-op phone call in person, or they can just reply to the text, everything's great, instead of people having to call. So there's just a lot of ways you can use it to limit labor hours at your center.
And what you just said a moment ago is like a dog whistle for me. That's a lot of labor. So 20 minutes on the phone on average pre-op per patient, not to mention talking to your practices and making sure, operative reports get routed where they need to go. Only healthcare, only healthcare. And thankfully healthcare is evolving and moving away from this, but it has been the classic healthcare fix. Just hire somebody, they'll do it. Hire another person when they run out of bandwidth. Not only is that not a great ethos to operate any type of a business, whether it's a business that cares for patients or not, but now you can't really do that. A lot of centers having a lot of difficulty hiring and retaining staff. They're either competing with their friendly neighborhood health system, or the talent pool just has seemingly dried up for them.
Yeah.
Obviously, technology can help you curb some of those issues if you're using it the right way to need less FTEs. But do you have any thoughts on like what is actually going on and what can centers do to navigate this weird hiring sort of paradigm we're in right now?
Well, one thing that's really important, and I see a lot, people, they look at total FTEs. Well, you also have to look at your total salary cost, because are your licensed professionals, your nurses, are they practicing at the top of their license, or do you have them spending tons of time on things that have nothing to do with their nursing license? such as, taking patients to their car in a wheelchair, taking vital signs, doing paperwork, all kind of things that aren't really needing to be done by an RN. You could hire nursing assistants, you can hire patient care assistants, you can hire other people to do a lot of these things. Even at charge entry, they have nurses spending a lot of time on that. Why are we having nurses do that? Editing in time, anything that's paperwork related, that's not charting, that they have to do, obviously. But other paperwork stuff, putting charts together, why would you have nurses do? I mean, just all kind of things that we do in surgery centers, that because we want to limit FTEs, but are we thinking about using the licensed staff at the top of their license? And you won't need as many of those. And those
Yeah.
are the people that are making the most money in your surgery center. I just reviewed a report yesterday about all the average nursing salaries in all 50 states. And it's gone up. I mean, it's a great time to be a nurse, I guess, as it always is. You can always get a job. It's a great profession. But, a lot of states are above $100,000 a year for average nursing salaries, just staff nurse. So, you have to figure out a way, just like anesthesia. We have to think about anesthesia in a different way, or we're not going to be able to afford it.
Yeah, and that's the other big piece of the puzzle. We talked about case profitability with utilizing block times right, having staffing there, understanding reimbursement, supply costs. Anesthesia, though, unless you're one of the lucky, very lucky few that has, I guess, employed anesthesia working for your center, you have a lot more to think about if you're
Yeah.
dealing with an anesthesia partner.
It's interesting because, like I said, I've been doing this for a really long time, and we were insulated at ASCs from anesthesia subsidies. You always knew hospitals were paying subsidies to anesthesia groups because OB coverage, all the different things. They're just payer mix, whatever, at hospitals, and they paid those subsidies. But ASCs, until very recently, we're not really having to pay subsidies for anesthesia, and now it's pretty much the norm
Yeah,
if you need anesthesia. And even I talk to my friends at very busy surgery centers, they're having to pay very large subsidies because the anesthesia salaries have just gone through the roof, especially CRNAs, and their reimbursement has gone down since the balance billing acts and things like that really kind of eliminated them using out of network models.
big
And
time.
that's where they were making up a lot of revenue on that out of network side, and they can't do it anymore. And unfortunately, Medicare pays them, I mean, like it's a pittance for what they do. It's
Yeah.
literally 3 to 4 times less than a commercial payer will reimburse them. And it doesn't even cover the salary of a CRNA. A Medicare, an hour of Medicare is way less than they have to pay one CRNA, So it's just the math doesn't add up, and that's why we're seeing all the subsidies. And so you have to that really pushes you at a surgery center to schedule in a vertical manner and not a horizontal manner, so that you're
Right. Well put.
yeah, because you're paying for all these people, and you've got to pay for their whole day, whether they're there for one case or 10.
Mhm.
So you have to really think about, okay, how can we do this coverage, and how do we schedule so we're not losing money on anesthesia, because it's become a very large line item.
Well, I tell you something, Rena. I'm hoping to bump into some folks that are much, much smarter than me at ASCA, and that won't be too hard to do. But especially just to talk anesthesia, because
Yep.
it serves the system right. And I don't mean Medicare, I don't mean the federal government. I just mean the whole system. Everybody that's involved in this. What did you think was going to happen if you decide you're going to pay less, pay less, pay less? No Surprises Act, which I have mixed emotions on as a healthcare consumer myself and my
Right.
family is. But then on the other end, like how are these folks supposed to pay back their tremendous medical bills and earn a living for the service that they provide? It
Yeah.
just doesn't make sense. This is a total disalignment of the incentive chain.
It really is. And anesthesia, I mean, many anesthesiologists are some of my best friends, and I mean, they're indispensable to surgery, obviously. I don't
I'm not
think,
having any surgeries
yeah,
without
right.
anesthesia. I'll tell you
I mean,
that.
I don't think, uh, obviously, the surgeons are bringing the patients, but our anesthesia colleagues are key and critical, to what's happening. And it's just become challenging. So we have to help them and work out solutions where we can continue to do what we do in ASCs at a in a cost efficient manner.
Cost efficient, and ASC is a place where it's a win-win-win for patients, providers, and even our friends at the payers. And that's what you have to do in dealing with anesthesia, is be really savvy with your schedule. Like you
Yeah.
said, schedule vertically, not horizontally.
And you also have to look at your payer mix. If it's really heavy on the Medicare, it's going to be you have to evaluate that. Do you have enough commercial payers to offset? In some markets, especially in Florida, where I know you are, there's, the highest Medicare markets in the nation are in some of the counties in Florida,
Yep.
where 70% of the population have Medicare or Medicare Advantage. So, it just depends. Where you go to Orlando, it's 25%. You go to, some of these other counties like Naples, where a lot of
Sure.
retirees are and things like that, and other areas of the country, the more Medicare you have, the harder it is for anesthesia.
Absolutely. Yeah, here on the East Coast, we've still got a pretty healthy mix. West Coast, as you said, Naples, Fort Myers. Maybe not so much Fort Myers, certainly
Not so
Naples
much,
though.
but in Naples, and then you get up, in the central Florida and a lot of those retirement communities up
Sure.
up there north of Orlando, north of Tampa, some
Yeah.
very
Can't
heavy
forget about our
Medicare.
friends at the villages.
Yes, the villages. There's, north of Tampa, there's county like Citrus County. That
Mm.
supposedly is the highest Medicare population per capita of any county in the nation.
Not a great place to be an anesthesiologist in 2024.
So yeah, you have to figure out, how you can make that happen and be creative in solutions that are obviously safe, but think it may change. You have to change your thoughts on anesthesia delivery and how that's done.
Absolutely. And I know we're wrapping up our time together here, Rena. Would love any thoughts that you have on AI in healthcare.
Well, it's the hot topic on everybody's mind, and it's on every media outlet. How are we doing? Of course. But I think in terms of ASCs, there's a few things that we really could benefit from right off the bat, which one is robotic assisted surgery, which we do now. Mostly, I would say in ASCs, it's more the orthopedic variety. But, that has a lot of advantages for patients, and because they use AI and determining preoperative, using medical records, imaging, and things like that preoperatively, it influences the surgery directly and may result in better outcomes for patients, and those are great. So that's one of the things that looks when you look at these technologies, that's one of the top potential annual value drivers, of AI. And then the other one is administrative workflow, which we've talked a little bit about. How burdensome is that? You can do a lot of things with AI to help reduce administrative workflow. It could be, templates. It's for dictations, for operative notes, all kinds of different things that could be used to improve administrative workflow. And then on the back end, billing and collections, and just some leaving messages for people, getting information from them. It all doesn't have to be done by a person. It could be done by AI. So
Yeah,
those
like
are
you said.
great ways. And then virtual nursing assistants, that are calling, giving, like, if you, I mean, maybe some set instructions or something like that, you can give. And a lot of places are employing virtual nursing assistants. We haven't done it yet in the ASCs, but it might be coming.
I imagine it's coming down the pike. Everything you just lined out was less labor, throw less labor at problems. I would tend to see it your way. I didn't hear any suggestions around what do you need a doctor for? You just stick
Yeah.
somebody in front of
No,
ChatGPT and ask them.
no, it's funny, and there's articles out there that you can find about, using AI in the wrong way, which would be, I read one but written by a friend, I think it was in Time magazine, and it was a whole case study about somewhere that had used AI to deliver laboratory results and pathology results. Well, that's okay, maybe, if they're normal, but I don't think I want to get a call from a robot telling me that I have cancer and I need to see a hematologist or an oncologist or whatever. So we have to be careful, because you still need that human factor in these kind of things.
That is, obviously, I'm laughing at the absurdity of that, not of anybody's cancer diagnosis. That would be pretty shocking to get
Yeah.
that phone call.
Yeah. It
Um,
was a real case study. It was kind of shocking. So I wouldn't say we want to do that, but
but
there's a
take me
lot of
off that
other
list.
great opportunities, I think, to again improve efficiency and decrease labor costs.
Well put. Hard to argue with any of those points, Rena. And then the thing that we ask our guests at the end of every show: what is the one thing that you wish every surgery center would either know or do?
Well, I think we know this, but we have to keep it in top of mind that ASCs, we in the industry of ASCs know this, that we're critical to delivering the triple aim in healthcare, and that's to improve the experience of healthcare, improve the health of populations, which we're doing by getting them back, getting them surgery, getting them back to movement, if it's orthopedic surgery, back to what they do, back to quality of life, and reducing per capita costs of healthcare, because it's imperative that we do that. And when you look at the spend we have in the US per capita compared to any other industrialized nation, but we as ASCs are a big part of the solution.
I love it. And if you're a listener of the show, you'll know that we fly the ASCA flag as high as anybody. We had Bill Prentice on last year. For those who may not be familiar, the leader of ASCA. If you have a friend that doesn't know what you do for surgery centers, and this is both for you, Rena, obviously, and for our listeners, tell them about a surgery center, because that awareness is a key piece to continuing down this road.
Absolutely. And we're saving billions of dollars for the Medicare system. And we could save billions more, the more codes that get added.
Just getting started. Yeah, we're whittling down that IPO list, and it's all good things. Well,
Absolutely.
Rena, as we wrap up here, where can our listeners connect with you? Are you big on any social media?
I'm on LinkedIn.
Okay,
Yep.
that's a
So,
good
and
one.
I get a lot of messages on there, and I do reply to them.
I know we are out of time for you, Rena, and on behalf of the entire DocBuddy team, I want to thank you for listening, and for you, Rena, for joining the show. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube, and we will talk to you on the next episode of the DocBuddy Journal.
Great. Thank you so much for having me.